Morning, everybody. Thank you so much for joining us today. I just want to thank you all for taking the time. As we approach the end of Mental Health Awareness Month here at No Patient Left Behind, we really wanted to spend some time on a topic that feels especially important all the time, but is also very personal to many of us. So for any of those of you who may be new to No Patient Left Behind, we are a nonprofit organization working to advance common sense solutions that champion both drug affordability for patients today and continued innovation for patients tomorrow. We're focused on access and affordability, as well as transparency and bridging that gap between what's scientifically possible and what's financially accessible for patients. I'm fortunate to serve as NPLB's executive director. Our coalition, we're made up of a whole lot of different folks, from innovators to patient advocates, physicians, health economists, and others who all share this common goal that we want to ensure that progress in medicine translates into real-world access and affordability for patients. As we talk about the issue we're here for today, when we think about mental health care and the mental health system, we often don't think about it until it's something that we actually need. And when we do, we realize just how difficult it can be to navigate that structure. And we have a number of folks with us here today to kind of chat through what that experience is like, particularly from the patient perspective. So we're going to focus on a couple of things today, specifically the growing disconnect between the fact that we've got mental health treatments that are advancing faster than ever, but we don't necessarily have the health insurance coverage systems in a place where people can access these things, and that they haven't kept pace with the innovation. And what that does is leaves patients and families sort of stuck in this limbo, waiting for approvals, dealing with denials, absorbing the emotional toll of a system that really wasn't built for what we have available to us today. So just a couple of housekeeping notes up at the top. As you can all see, this session is being recorded. So we will have it available. You can revisit it. You can feel free to share it afterwards. And we will have both chat and live Q&A open throughout. So please jump in, share any reactions, engage as we go. We'll try to answer questions, but we do have a dedicated Q&A session ready for the end of once we're all done speaking. So very quickly, I want to introduce you all to the folks that we have with us today. And we have a variety of perspectives, but they're all very connected to each other. So we've got Dr. Thomas Hyde, who is the Chief Medical Officer at the Lieber Institute for Brain Development. Dr. Hyde's a leading neuropathologist advancing research in neuropsychiatric disorders. He'll help ground us in what's actually changing in mental health treatment and in the innovation, what's coming next, what does that mean for patients. We've also got Carol Harris. Carol is the co-founder and executive director of Avery's Hope and a grandmother to a child with a rare disease. She has spent years watching families, including her own, navigate financial strain, insurance barriers, the emotional weight of long-term care. She'll talk about how families and community organizations step in to often fill the gaps when the systems fall short for patients and families. We have Michael Kramer. Michael is a lymphoma survivor and a GVHD trial participant. He has navigated our healthcare system firsthand at a very formative stage in his life. He's experienced the uncertainty, the waiting, the mental health impact that comes with a long and complex care journey, and he's turned that into a phenomenal advocacy network where he is supporting other young people going through similar experiences. And then we have Ashley Kramer, who's Michael's mom, and is also a tremendous advocate and a caregiver to both her son and her late husband. Ashley brings a really powerful perspective on what it looks like to hold a family together while navigating our very complex and difficult healthcare system when it comes to denials and delays and the constant uncertainty that we deal with when it comes to a serious life-altering diagnosis and the toll that takes emotionally and mentally. So you'll hear the research perspective. And you'll hear the lived experience perspective from a range of voices as patient caregivers, patient advocacy professionals. And I'll just share really quickly for myself. I'm also a patient, have been for most of my life, and can speak very personally to the mental health toll that comes along with having a lifelong chronic condition and the challenges that result from that as you're also trying to deal with a very serious illness. So what is happening? What is the sort of situation we have right now when it comes to mental health care and mental health coverage? So, as many of you may remember, maybe not, but it has now been over a decade, we passed what we call mental health parity laws, which were meant to ensure equal coverage for both mental care and physical health care. Unfortunately, that enforcement remains rather inconsistent, and we still see health plans imposing stricter limits, narrower networks, higher out-of-pocket costs, very often for mental health care treatment over physical healthcare treatment. So that parity, while it exists on paper, is very often not people's lived experience. So what we end up with is a system that is failing, and the stakes sort of being higher than ever. So the scale of the issue, and I think as we've all lived through the pandemic, we've all sort of seen the impacts of that, and I think it has really brought mental illness and the challenges that exist from that really front and center in a way that I don't think was as focused on and as public as it was before. So as we look today, we've got over 61 million adults who have a diagnosed mental illness in the United States, and nearly half of them have received no treatment for that. 2/3 of individuals who have insurance with a diagnosed condition still can't access care for that. And unfortunately, on average, much like in the rare disease space, when it comes to mental illness, it can take up to 11 years from when somebody starts experiencing mental health challenges to when they actually are able to secure treatment for it. So what are the consequences when these issues are left unaddressed? It's not abstract. These represent very real consequences for real people. I wouldn't hesitate to guess that almost every single person on this call has either personally experienced this or has families who have, and what happens when the system fails. You've got very tangible and very personal impacts. It's not just that we have higher hospitalization rates and higher cost, but we also have a much greater loss of life, which is completely preventable in many cases. We have higher rates of incarceration. We have higher rates of homelessness. We have higher rates of all sorts of really terrible outcomes that could be prevented if people were able to access the care they need. So as we think about all of these giant issues, I think where we want to focus today is particularly on the coverage gaps that we're looking at. So what are when it comes to accessing medicines in particular and breakthrough medicines as well, what can we as advocates do to help that? So we can either further break it down. It's often even more relentless, these challenges for people living with rare chronic conditions and where mental health strain is consistent and frankly, dealing with that illness can actually create more, especially when you're dealing with denials and coverage challenges for your chronic and rare disease at the same time can spiral and make the mental health strain even worse. I think what is particularly frustrating for a lot of us is that as coverage is failing, we're trying to keep pace with what we know is an evolving innovation landscape, with the breakthroughs happening all around us, including in mental health. And I'm really excited to turn this over to Tom to walk through some of that. And what's in the pipeline today that patients and advocates and family members and caregivers should know more about. So as we take a deeper dive into the innovation space, Tom, I really wanted to turn it over to you to start putting a face on some of this and talking a little bit about where there is actually reason to be excited in this space.
Great. Thank you very much for inviting me to participate in this forum. So this is an interesting time in the innovation space in mental illness and mental health care. We have a lot of medications. Many of them are very similar in their mode of action and their side effect profile. So whether you're talking about treatment for anxiety, depression, bipolar disorder, schizophrenia, we have a fair number of medications that are designed to treat those disorders. When we come into the realm of something like post-traumatic stress disorder, however, we have no medication that is indicated for the treatment of that disorder. When we talk about eating disorders, we have a very mixed bag as far as treatment. So for some psychiatric diagnoses, we do have treatments that, for the most part, are effective in most patients with a reasonably acceptable symptom profile. But for some illnesses, we don't even have any treatment. And so there is a lot of research, or at least there was a lot of research being funded by the National Institute of Mental Health that was focused on developing new treatments that are more efficacious, work faster with fewer side effects, and also treatments for disorders that there are no medications or other forms of treatment that are translatable. So within the medication space, one of the goals is to try for those people who need to be on chronic maintenance therapy, and those are usually patients with things like schizophrenia, where you need to be on a medication all the time, virtually for the rest of your life. And compliance is an issue, both from a convenience point of view, as well as the patient willingness to comply with medication. Injectables are becoming the watchword, especially for the new class of antipsychotic medications that have fewer side effects and are more efficacious than our old antipsychotic medications. And they're preferable because they can last anywhere from 2 to 6 weeks with a single injection. It improves the compliance, especially in those patients who are under conservatorship. So if you have a family member with schizophrenia, oftentimes there is some resistance, and at some point they may end up under guardianship or conservatorship. And this will be significantly helpful in improving compliance and, of course, clinical outcome. So there are injectables that have been developed recently, and they work well. For treatments of bipolar disorder, depression, anxiety disorders, attention deficit hyperactivity disorder, we still rely upon daily dosing. Many of the medications are now once-a-day dosing, so we have extended release oral formulations. And there's always room for improvement. Just as a general concept when talking about mental illness, when we look at a brain of somebody who has Parkinson's disease, we have a pathology that we can look at under the microscope and say, this person has this clinical symptom complex, and then we can look at their brain of that individual when they pass on and find a defined pathology that correlates to and explains their symptom complex. We do not have a single psychiatric disorder, behavioral disorder, where we can do that. We do not know the pathology. Therefore, the biological basis is somewhat obscure in all of the disorders. We know that there are genetic components, but they're not purely genetic. We know there are environmental components, but they're not purely environmental. Everybody who experiences a trauma, a witness death, not everybody, for example, in the military who's in combat and experiences death and destruction around them comes home and develops PTSD, but a higher percentage do than the general population that is not exposed to that type of trauma. So we know some of the biology of these illnesses, but we don't really know the pathology, the pathological basis. That inhibits the development of treatment. So for cancer, we know what a cancer cell looks like. We know the biology of a cancer cell. We know the genetic changes that occur in that cell to make it into a cancer cell from a normal cell. And we can target those changes. And in the case of cancer, we can try and kill those cells. And we have an advancing arsenal to do that. And we're getting more and more successful. We're lagging way behind in understanding the pathology of mental illness. And so there has been, especially during the Obama and Biden administration, a lot of money that was dedicated to understanding the biology of these illnesses. If you understand the biology of the illness, you can hopefully develop some targeted treatment. And so the long-acting injectables are one new line of therapy. For postpartum depression, there is a new treatment that is hormone-based, and that has to do with the massive hormone shifts that are changing in women between the ninth month of pregnancy and after giving birth. And in a subset of individuals who have given birth, those women develop a severe postpartum depression, which poses a great deal of danger to both the mother and to the child itself. And so we want to reduce that depression, and we want to treat it rapidly. We don't want to wait for 6 to 8 weeks for a conventional antidepressant to kick in. And so there is a new hormone treatment or hormone-based treatment that seems to be working very, very well for postpartum depression. Of course, getting access to it, getting it approved on the formulary of insurance companies is something we can talk about later on in this discussion group. A lot of attention is being dedicated to psychedelic-associated therapy. And so for those of you who have kids, or maybe yourself, who've experienced MDMA, popularly known as ecstasy, it seems to reduce people's anxiety, but also makes people more in touch with their emotions, perhaps, and more able to explore and express their feelings and experiences in a less inhibited personal space. So people have been exploring the use of MDMA in conjunction with counseling. People have used psychedelics like LSD and psilocybin in treatment. And ketamine, which can have some psychedelic-related effects, has been approved for the treatment of depression. So there's a lot of research going on in that sphere. I'm not sure where that's going. We'll see. But clinical trials are the best way to figure out what is a placebo effect and what is actually therapeutic effect. One thing we don't have on this slide are non-pharmacological treatments that are being developed. Transcranial magnetic stimulation is one area that is being used in place of electroconvulsive therapy with some efficacy for OCD and depression. And there's even being tried in anxiety disorders. And so that's very exciting, new development. And there's been a lot of reticence among the general population, some based upon fiction, some based upon fact, to using electroconvulsive therapy. So transcranial magnetic stimulation, which doesn't involve paralyzing or sedating the individual, seems to be something that looks exciting. And it basically uses something similar to an ultrasound probe to stimulate parts of the brain that may be involved in mood regulation. So that's a new and exciting area. For individuals who have really severe OCD, and even for treatment-resistant depression, people have been using deep brain stimulators, which are first pioneered for the use of treatment of Parkinson's disease, to stimulate certain parts of the brain that seem to be underactive. And for those people with really treatment-resistant depression or OCD, they have had some very good therapeutic effects. This is a really interventional treatment. They have to drill a hole in the skull. They have to insert basically a lead into certain parts of the brain and have it hooked up to a stimulator, similar to what you would have with a pacemaker in the heart. So this is not something that you would want to run into easily or quickly, but it is something that is very exciting and is coming down the line for those people who have that subset of patients who just do not respond to any medication or other forms of pharmacological treatment, and that are really disabled by the disorder. So that's a quick overview of where we are.
Thank you so much, Tom. That was incredibly helpful. And I think the excitement being there's so much going on in the space, and we're seeing all of this exciting innovation and development going on. So what does that mean, though, when we're talking about the coverage issues for some of these new therapies, whether those are pharmacological or some of these other more groundbreaking treatments that you focused on, that getting them through the approval processes is one thing, and then getting them to patients is another. So Carol, I wanted to have you jump in and talk a little bit about what it means to focus on the coverage issues that we've talked about. and the access challenges that we see pop up when families and patients are dealing with these challenges.
Thanks so much, Priscilla. Avery's Hope, the organization that I'm involved with and run, we hear from patient families all the time trying to navigate the system. And access is the big word. How do we get access to treatment? How do we get access to care? And very often we think of that as an umbrella, when in fact it's much more like a set of stairs or a ladder with the top rung being access. People might be able, patient families might be able to take a step up. They may get their prescription, not denied, or they get it denied. And then they have to take a step down to try to get that approved. And I have a really good real world story from a patient family. We had a patient family with a very medically complex young teen who was struggling emotionally, primarily because of their disease and trying to function in the world. And the physician prescribed something for his depression that would work extremely well with the medication he was already on. He also suggested that this teenager see a therapist. Well, they got their prescription denied, which is typically the first step. We see this all the time. And the therapist would be out of pocket until the deductible was met. And then there'd be a copay until the out of pocket was met. And so what happens is with a family that, is not necessarily at the Medicaid level, but not exactly capable of handling big out-of-pocket and high deductibles, we now have a patient who can't access the care that they need. And while patients and patient families and the physicians fight to get these prescriptions and this therapy approved, what happens is it's too astronomical for these families, and they can't afford to meet their deductible or their out of pocket. And so what happens is, in this situation, we have a medically complex teen who is now, by the insurance company, defining him by his disease and not as a whole person. And this affects the entire family. It is incredibly frustrating to the point that it's emotionally exhausting. And I sometimes think the payers are hoping that the families are going to be exhausted by this and not go back and fight. And very often, if they're working 2 jobs, they don't have the bandwidth, the time to be able to fight these sorts of things. And so therefore, the patient is denied care. It's a very upsetting and a very emotional toll. And I'm going to pass it on to Michael, who I think can really talk to this with his own experience and his own lived experience with going through the process.
Sorry to unmute there. Yeah, so I was actually very lucky in my experience. The hospital I was at, they immediately put me in contact with a therapist and the whole mental health team. I was just diagnosed with cancer as a 19-year-old, and right off the bat, I had a therapist. I had a wonderful therapist. She understood me and my journey with cancer, and then now chronic GVHD. We built a relationship. We would talk about once a week for almost 2 full years. And during some of my lowest moments, she was my therapist. She was the one who saw me in the hospital, saw what I was going through physically and mentally. But then when my insurance changed and we had to get a new therapist, I went through a few therapists that did not understand my journey or my struggles, and they made me feel bad about myself, because when I told them about all I had gone through, all the mental things I dealt with, the depression, the anxiety, they couldn't understand it, and they made me just feel like I was crazy. I finally landed on a therapist that I'm now really happy with, but then our insurance changed again. And now therapy is not something that's covered by my insurance, so we have to pay out of pocket for something that feels like it's necessary, especially as a chronic illness patient. And what's even crazier to me is that I lead a support group online for cancer survivors and cancer patients. I've been leading it for years. And the other day I decided to ask them if any of them had their hospital set them up with a therapist or a psychologist, and everyone's response was no. Not a single cancer survivor in that group had a therapist through a hospital or was offered real mental health support as part of the treatment plan. And it shocks me because this is something that is so fundamental and important in the journey of a cancer patient and really in any patient, especially for young adults battling an illness.
And I am just going to tag on there. And this actually goes back to what you were just saying, Carol, because this does, it 100% affects the whole family. By the way, I'm Michael's mom. I think some of you saw that on the first slide. So I have 3 kids. Michael has 2 siblings as well, his older brother and younger sister. And we saw Michael facing this cancer diagnosis. And in the beginning, it's true. So we were lucky he got Medicare right away, but we were one of those people that it ended up changing. He had Medicare with disability, ended up changing, insurance changed, and as Carol was saying, caught in the middle. But anyway, in the beginning, he got his treatment, he had his therapist, and we were all I even remember with my kids, we made this video about his mental strength. And I remember filming his mantra was, I am a pillar of mental fortitude. And he really was. But then time went on. And as he said, it's a chronic illness. So time lingers. And we saw his mental struggles. And as his time, especially as his time in the hospital lengthened. And I would say almost a year and a half in, Michael was super low and he wasn't exactly getting all the mental help he needed and his body was exhausted. And as his mom, I'm doing my best to lift him and be positive and give him energy and love. But this is something that I think the caregivers, the mamas, the wives, the family members, we learned that we can't control the physical health. We cannot control the mental struggles either, just offer support. And his brother and sister too, they were watching Michael struggle and they felt helpless and they felt his despair too. And the insurance that did cover in the beginning, his therapist was not covering a therapist for brother and sister. So I'm just going to say, this affected all of us. And I think that's something we don't always think about is the siblings, the caregivers, the parents.
So true.
Yeah.
Priscilla, you're on mute.
Here I am thinking I'm talking. Tom, what does this look like for the provider side? I know you're spending a lot of time on the research side, but obviously you are in a space where you're looking at filling these gaps for patients. Once you get them in the door, what does that look like for a provider to try to navigate these issues?
Well, so just to disclosure, I'm an MD PhD, so I'm a board certified neurologist with additional training in psychiatry, and I'm one of those rare neurologists who sees patients with both psychiatric and neurological conditions. So I treat the unusual patients and some of the more treatment-resistant patients. And although I don't see private patients anymore, I did see patients both in the research sphere and continue to see some patients in the research sphere now. And I also still do forensic consulting with the Public Defender's Office with the state of Maryland and a few other federal public defender offices around the country. That's a whole other issue of the intersection between the criminal justice system, mental health care, mental health access, and the use of jails in place of residential treatment facilities. That can be a whole nother seminar at another time. But there's a few things that come up. Number one, the roster of therapists, psychologists, psychiatrists, psychiatric social workers, and counselors that most healthcare provider networks, i.e. insurance companies, have for approved providers is, in my viewpoint, kept artificially low to deny access to people. So even if you can find somebody in network, so to speak, which would lower your costs, oftentimes they're not taking new patients. If they are, the waiting list could be 6 months to a year or longer. So it's absolutely absurd that they're allowed to keep their provider network so circumscribed that although they say they provide access to mental health care, it is covered under your insurance, practically speaking, it's a fiction. It's a fantasy. So that's one problem. Number two, that if you shift insurance plans, the provider network changes. And since therapy and counseling is such a personal experience, it's not like anybody can prescribe your medication for your high blood pressure. That's a relatively fixed diagnosis. When you're talking about people with behavioral health issues, there's a trust component that comes in that is essential to making progress. And there's a lot of background history that you end up having to regurgitate, which in and of itself can have its own trauma and negative effects. So the fact that we don't have wide networks, that the networks are so circumscribed that nobody limits your number of sessions that you can go to have your high blood pressure checked. But they do limit the number of sessions that you can go to. And then they also, if it's an out-of-network provider, so assuming your insurance will pay anything for that, they often impose a much higher deductible on out-of-network. So you may have to pay $1,000 or $1,500 or $2,000 to see an out-of-network provider before you get a single penny of reimbursement. The problem is fundamental to our whole healthcare system, and that is that we have huge administrative costs, which are over the top. We have a convoluted system for access to care. We have a convoluted system to which providers are enrolled in a particular health insurance plan. And I don't even want to talk about medication access and how formularies change arbitrarily. So somebody who may be stable on an antidepressant for 4 years is told that their formulary is no longer covering it and they have to change medications, which is not very easy to do with any form of medication, but it's especially hard to do with behavioral health oriented medications. So navigating the system, you have to be persistent, and you have to recognize that you may have to use your own personal resources. I will say that there are sometimes higher and lower cost options for people to consider. So psychiatric social workers or licensed therapists are often, if you have to pay out of pocket, just as good as a psychologist or a psychiatrist for talk therapy. But you have to find somebody who's good and well trained and certified, but it can be a lower cost option for people. Generic drugs are often as good as brand name, and it's better to take a generic than not to get anything. If you're having a treatment resistant problem, clinical trials, if you go to clinicaltrials.com, at the government website, clinicaltrials.gov, you can see in your area, if there's a major medical center, there may be a trial of a new medication or treatment program that you can get into, which will be free of charge. So there are a few options, but it's a pathetic state, and I'm not going to sugarcoat it.
Yeah, no, I completely agree. And I know, Ashley, you've got a couple of examples of what this has meant with your family and what that disconnect has meant as well.
Oh my gosh. I'm just going to say, Tom, I relate to every single thing you said. Like everything you said, part of our lives. But I want to go to knowledge gaps. That's like another topic. We didn't really touch on it yet around treatments. And sometimes there's like this communication gap between providers. So as you know, Michael, my son has been going through cancer and chronic illness now, but my husband actually went through cancer as well. And when he was going through cancer, he was also struggling mentally. You know, it's hard going through it's hard going through chemo and treatment. And there was a night when he was admitted to the hospital for one of his cycles of chemo, and he had just started a new antidepressant. I was at home, I was with the 3 kids, and he called me and he was completely freaking out. And he was telling me about a hostage situation at the hospital. He was totally convincing. And I was like, I was freaking out. Like I raced to the hospital. And I arrived and I'm like, wait, there's nothing going on in the lobby. So I get in the elevator, I go to the 8th floor, nothing going on. Everyone is calm. I go to my husband's room and he's sitting there with, this terror in his eyes. And he's imagining that there is a hostage situation going on and there's nothing going on. He was having a reaction between the chemo and the antidepressant, and they figured that out, thankfully. And within a few days, the effects wore off. But he had this complete panic. And to this day, my heart is broken. I still feel this pain for him. And then I have another really quick example. There was a time that Michael, with his graft versus host disease, they had him on prednisone for a very long time, a very high dose. And the dose was so high, he was not sleeping. Many of you may know that when you don't sleep, that affects your mental health. His personality kind of started to change. And he was at a pediatric hospital where they didn't have a lot of experience, I think, with this. And they told me they had, he was completely down. They told me they had never really seen someone affected like Michael was affected. And so, of course, I feel responsible, or like maybe he was responsible for his hopelessness. And he hit rock bottom of despair before they finally listened to me, and actually his therapist as well. We both advocated and got him off the steroids. But I'm going to tell you, it was almost too late. And he was really lucky to have us as his advocates, and his doctors did not catch it. And of course, they were focused on his body. They were focused on getting his disease under control, but they were not focused on his mental health, which was equally as important. They were not focused on this whole person, unfortunately. So I think, how can we heal if we have no hope?
Yeah. I've been on prednisone most of my life, so the struggle is real.
The struggle is real.
Yeah. And, I think we talk about this sort of cumulative burden, and I'm going to run through this quickly because what I really want to get to is a few more of these personal anecdotes on what this looks like, and what kind of the repeated challenges that Ashley has just gone through, and that Tom has flagged and Carol has flagged around what is the broader cumulative burden of all of this on patients, on families, on the system writ large. So as we jump ahead, I think I'll start, and we can kind of do a little bit of a round robin here, because Ashley's experience isn't an edge case. Carol. So, for example, what are some of the barriers that have shown up most in your experience? What feels most urgent to fix, and what would that progress look like for you? Particularly on that family impact and care navigation side of it.
Well, I think it's really important too to remember that when you have a rare or a chronic disease patient in the family, it affects not just the parents and caregivers, but the siblings, and dare I say the grandparents. It really changes everything. And so I think there's not just one thing that needs to be changed. We need to look at access not as stepping up and all these different steps. Access. Patients need access. Patients need the care and treatment. They need to be able to get to care and treatment without having to worry so much about these out-of-pocket costs, because it does affect the entire family. Think about a sibling of a young pediatric patient. There isn't a lot of money going around. Everybody's focused on that child. The whole family needs mental health, or access to, if they want it, access to mental health care. And that's what needs to be changed. They need access that's easy to get, that's reliable, and get anything they need for the entire family. Because any rare or chronic disease is not just the body, it's the whole person. And we need access for that to happen.
Yeah. And Michael, Ashley, as we think about these barriers, are there other challenges? I think we've touched on this a little bit, but as we think about the exclusions of prescriptions, or having to go through step therapy or try to get a referral, are there other types of treatment that may not be covered by insurance? So things like exercise, yoga, what can actually help in addition that may not be covered by insurance? Are there other barriers here that either of you wanted to touch on as well?
I'm going to jump in. Michael's going to talk first, but I'm going to jump in because you mentioned that. I think that there is a big gap between what evidence shows helps and what the insurers like actually cover. So there is evidence of things like exercise and yoga and wellness and diet may be paired, with medications, with SSRIs. I'm not denying, definitely not denying the benefits of medications when you can get them. But there are so many modalities that help the whole patient. For Michael, getting back to the gym has been huge. But I'm going to tell you, the insurance is not covering his gym membership or other wellness therapies. So I think that's a really big gap. And I want to touch really quickly on caregivers. Carol, you also mentioned it, like the siblings, but I do see this over and over for caregivers as well. Like maybe the loved one ends up that they are covered with disability or Medicare or Medicaid or maybe their insurance or whatever it is. And in Michael's case, we do make it work. But I will say this, the caregiver, like, I'm going to pay the money for him to see a therapist and not me. That's just the bottom line. And for us, we're blessed to have a cancer center that does offer a lot of support. Doesn't cover anything for me. I'm not included in that even though I'm his family, I'm his mom, his caregiver. So I know there's foundations like Avery's Hope that does a lot. I know there's foundations out there, but right now we're talking about our medical system. So I think there's just, we need to expand that care to the caregivers as well, because caregiver burnout, PTSD, these are real conversations, and it's not because caregivers are like fragile. But our human nervous systems, we are not designed to sustain prolonged uncertainty. And that's what it is. So I think caregivers need to hear this, that struggling mentally under these circumstances doesn't mean you're failing. It means you've been carrying something heavy for a long time. And I think if we care about patient outcomes, we do have to think about the mental health for the patient, but also the caregivers, as Carol mentioned, also the siblings. And I know Michael wants to talk about another barrier, so I'm going to close my mouth right now because I'll just keep talking.
Yeah, I totally agree with everything you said, Mom. And I think I was never given exercise or yoga as meditation as part of my treatment plan. And there's so much research on this stuff, and it really should be part of the whole treatment plan, treating the patient as a person and not just a patient. And also, really the barriers that I've seen show up now really are just like the delays in care. This is a huge one. I feel like scheduling an appointment with my therapist or my psychiatrist, it's always such a mission. It takes so much time, so much time
Maybe
to
it's
get
what
an
Tom
appointment.
said earlier, talking about like not enough providers.
Exactly. That's what I'm going to say is that, mental health care, it's something that's like really urgent, but sometimes the care we receive doesn't always match that energy. And that's not because it's the provider's fault or the therapist's fault. It's because the system is so rough that therapists and psychiatrists are overbooked. They have so much on their plates, and it makes it hard to communicate with patients frequently. So to get an appointment, you really have to schedule them a month or two in advance, which can actually delay the care. So that can be a huge problem.
Just if I could just interject a few points. Number one, you need to understand this is a designed feature of the system. This is not a bug in the system. This is how insurance companies have structured the system to make it as obtuse and difficult as possible to people, especially if you're in the throes of depression or anxiety or psychosis or trauma, where you may not even have the mental energy to pursue it. They would want you to give up because that improves their profit margin. As long as we have for-profit insurance in this country, where the profit margins range anywhere from 10 to 20% for these companies. Health insurance companies are among the most profitable insurance companies in this country. When's the last time you heard of an insurance company going bankrupt? I defy you to find one. And so they designed this in to make it difficult. And they know that the people who are most vulnerable are going to give up unless they have a family member who has the energy to jump in and act as a proxy. That's number one. Number two, there's no excuse in this day and age when you can make your airline appointment online, you can book a restaurant in Japan from Rockville, Maryland online, when you can make your car appointments online, that doctors do not have online scheduling. It just is ridiculous. And I don't understand why that should not be a requirement now for all practices. So you can see, when does somebody have an opening? You can check in to see, did somebody cancel? Can I get in earlier if I need to be seen? And then I think that if insurance companies are going to have filters, which are doctors and nurses who are contracted employees to approve or not approve care, that those people have to be licensed in the state in which they're issuing the denials or approvals, so that they are governed by the licensing body of that state. That's number one. Number two, if they issue a denial based upon the information they have, they should be subject to the same malpractice rules that any practitioner, because they are, in a sense, as a gatekeeper, you are practicing medicine. And so I think if first of all, we need fundamental reform of our whole healthcare system. I doubt we're going to get that anytime soon. But I think that if we can start operating around some of these margins, we can make some progress. We did make some progress with the healthcare access bills between 2008 and 2016. I think under the current administration, we're in a tough pickle.
Yeah. Thanks. And I think we've outlined a lot of what's on this slide here, the idea of the sort of broken by design and all of the various challenges that folks have. And a lot of these are related to, medicine, but they're also related to specific types of treatments, the denials of it. All of these challenges are very well documented, and you've all sort of flagged them significantly. And I think there are a few pieces here that I think what we want to do now is sort of transition over to what can we do about this? What are some of the things that we could push for that could help start to chip away at some of these barriers? And, I know when we talk about things like denials, when we talk about prior authorization, there's been a lot of conversation about that recently. There's been a lot of commitments made by insurers to speed up and make those processes better. But none of that is backed by any enforcement. It's all optional, and we haven't seen the proof of those coming forward yet. So what does that look like? When we think about things like step therapy, where an insurer will want you to try a lower price therapy for going to a higher one, that's totally fine, but it shouldn't. If a patient has been through that process and found a treatment that works that they're on, if they switch insurers, they shouldn't have to go through it again, especially when it comes to mental health and mental illness. And finally, the out-of-pocket cost situation that we've talked about here, that you've got people with massive out-of-pocket cap limits up to $12,000 per year. There are no limits on what you have to spend out of pocket to get your medicines. How are we dealing with all of this as we think about what types of reforms we could be pushing for? So, I think if anybody wants to kind of flag any of that, would be happy to hear any examples or any further info there. I don't know, Carol or others, if you wanted to jump in.
Yeah, one of the things I wanted to mention is that, because we haven't really said this out loud yet, but rare and chronic disease patients are marginalized to begin with. And then you add in these layers of gatekeeping, and it's absolutely devastating to the families, both financially and emotionally. And that's something we have to really think about. When we talk about denials, what is the percentage? I mean, I've heard as little as 75% denials the first time out, up to in the 90s. It's unacceptable. Prior authorization, before the prescription is even written, you're going through hoops, you're climbing up steps. Step therapy. I mean, every time a family changes insurance, or even if you haven't changed insurance, sometimes they will ask you to change your particular drug because it's too expensive. Well, that drug may have been working for a very long time. Why in the world would you change it? In our world, in the GI world, if you're on a particular medication for Crohn's, let's say, forget about mental health stuff, just your basic body stuff, you can't just switch medications because you can never go back. So these are all the kinds of craziness that we're seeing. I think Tom really said it the best. It's systematic, right? And it's a system that's designed to really not help the patient. And to move forward, we have to make some really big changes in Congress. We need to change step therapy. It's been sitting on the floor for how long now? Our out-of-pocket costs are astronomical. And there's no reason for a denial. Can we please speak to a human rather than to an AI robot? There's so many things that need to be changed, and this gatekeeping really has to stop. One of the things that we do as an organization is we're so frustrated with this. We've partnered with other organizations. We partnered with Basic Care Plus. It's not insurance. It's in addition to insurance. It gives you co-pays. It helps with telehealth. But most importantly, it gives every single person in the family who lives under the same roof, 8 counseling sessions each. Now, 8 is not a lot, but it's for every member of the family, and it's a start. The other thing we did is we're so frustrated with families not getting what they need that we started with another organization called Connecting Pieces. We started a healing arts program where we hired visual arts therapists and yoga therapists to give families, whole families, respite. So I'll stop talking now. I just got very frustrated with that particular slide. It's very frustrating to our families.
Yeah, no, it is.
Just one point I wanted to make as we wrap up. People want something concrete to do.
Yes.
Number one, you have to register to vote. If you don't vote, your health care is never going to change. It may not change anyway, but there's no hope if you keep voting or are so beaten down by the system that you don't participate in the civic process. Number two, contact your representatives. And I think that we need to think about what concrete steps particular organizations could take. So for example, in my pet idea is that the appeals process should not go through the insurance company, because that's like asking daddy to give you keys to a new car when he's already told you 5 times no. They're just going to tell you no, whether they have a good reason or not. They should have to contract with an independent third party whose level of approval or denial is not dependent upon their retention as the appeals company. And the appeals company should have strict standards, rules, regulations, and procedures to understand for basic clinical questions what should be approved and what should not be approved.
Yeah. Yeah. And so as we start to wrap up, I do want to give our participants some time for Q&A, so we can jump ahead to the next slide, where what are some action items? Registering to vote, engaging in the political process. Amen. I'm here for that. Knowing what we're up against. I think for patients, our coverage can change every single year. So we shouldn't assume that our medicines, our providers, our benefits are still going to be covered. So making sure that we're looking closely at all the formularies, all of the things. Bookmark webinar resource hub. If you click on the little code at the bottom, that will take you to our page where all of this information is available. We have a whole series of resources available for folks on what to look for as you're dealing with your insurance. There's a group called the Kennedy Forum. This was founded by Patrick Kennedy, former congressman, one of the Kennedy family, but he has been very open and very vocal about his own mental health challenges. And they advocate very directly for ensuring that mental health care is covered as equally as health care, and to improve health care coverage writ large. That the Loop Coalition, which is the Lower Out of Pockets Now Coalition, they do a ton of work on holding insurers' feet to the fire on these issues. So we strongly encourage folks to join up and be a part of the Loop Coalition. Absolutely think about some of the legislation that we've highlighted here, capping drug out-of-pocket costs, making sure that any spending on medicines goes to your out-of-pocket limit so that you're not being nickeled and dimed, advocating for protections, for better prior authorization reforms, for all of the things that we've mentioned today. So strongly encourage folks, go here. You'll learn more about Carol's program that they have with Avery's Hope related to art therapy and other ways of helping people manage these conditions. You can learn more about Michael and Ashley and their story and Michael's incredible support network that he's created online. But with that, I would love to offer folks a couple minutes to ask any questions of our attendees, and we can stay on for a couple more minutes if we do run over. So happy to open it up to Q&A. I'm not seeing any. So I will turn it over to my co-panelist here for any final thoughts that all of you would like to add, or any additional info or plugs you want to make.
I just want to offer one thought. One of the things I've always been impressed with as a practitioner was even from a behavioral health, which is not their strongest point. Kaiser, and I have no affiliation with Kaiser Permanente, I want to make that clear, offers much more comprehensive coverage for both psychiatric and therapy than most health insurance plans do. They have much better access, and they have much better continuity of care, both in their formulary and in their and the quality of their psychiatrists, psychologists, and therapists. So if that is available and financially it's within your reach, and it's usually one of the more reasonable cost health insurers, if you do have a chronic mental health condition, your current therapist or provider may not be covered, but you will not fall out of coverage, and you will not have arbitrary changes made in your formulary the way we see many of our private insurers are doing it this day. So it's at least something to keep in mind in the Mid-Atlantic region.
I would also suggest, if you are somebody who leads an advocacy organization or a disease organization, to take a look at Basic Care Plus and what they offer. It's very, very reasonable. Avery's Hope is a small, all-volunteer organization. We pay $15 a month per family for people to gain access to this program. And if you do it just for the mental health alone, it's really very well worth it, particularly when you think about the whole family. When I think about siblings, as well as the patient and the caregivers. You can find it in the resource hub, I believe, and it's very well worth looking into. We, at this point, only help about 6 families. We're hoping through grants and other private donations that we'll be able to expand on that and reach many more patients. But in the meantime, it's something that if a lot of organizations did, we would at least be reaching more families and more patients.
That's great. Thank you, Carol. Michael, Ashley, any last thoughts from all of you?
Yeah, if anyone here needs support, if anyone here on this call is going through cancer or knows someone going through cancer, reach out to my mom and I on Instagram. My Instagram is Michael Reed Kramer. Ashley Kramer will answer. We're here for you guys.
Yeah.
Thank you so much. You guys are great. And as my colleague Hallie put in the chat, all of the information from today's session will be available on our resource center. We'll be sending that out to all of you, as well as other folks who had registered. Thank you all so much for joining, and just a wonderful conversation. And listen, we are not helpless in this, and there's a lot of actions we can all take. So encourage everyone to be involved. Thank you so much. Have a great day.